afternoon. This is Module 6 discussion. We'll be talking about prescription drug abuse and addiction and how opioid products such as Vicodin and Oxycontin are prescription drugs that we have talked specifically about this week, but we'll talk about how we'll see signs and symptoms of abuse, opioid abuse, such as physical, verbal, nonverbal, psychosocial. We'll talk about behaviors which a person abusing opioids will see, best practice for healthcare providers, and clinical practice how to address possible abuse in new patients. First off, let's talk a little bit about opioids. Opioids is anything, in general term, referring to any substance, natural, synthetic, often used interchangeably with opiates. Pharmacotherapy with opioids is primarily used to relieve moderate to severe pain. Proper dosing, it can relieve any degree of pain. In large quantities, it can produce euphoria and severe central nervous system depression. Narcotic is another term commonly described morphine-like drugs or opiate-like drugs, and they specifically work on central nervous system depression. Central nervous system, not necessarily depression. Opioids exert their actions by interacting with at least 6 types of receptors in the central nervous system: mu, kappa, and delta. There are 3 major types. From the perspective of pain management, mu and kappa are the most important. Activation of mu receptors is responsible for the analgesic properties of the opioids, as well as some of the adverse effects, such as respiratory depression and physical dependencies. There are several other drugs that interact with this, so opioid antagonists, basically your morphine, codeine, mixed opioids. These are drugs that may accompany one receptor and block and have no effect to the other, such as like Stadol or Buprenex. Opioid antagonists, those are blocks, such as like Narcan. That's what you give to reverse an overdose. Opioids do not lower the threshold of pain. It does not slow or block transmission of pain impulses. It necessarily just affects the perception and emotional response to pain that is altered. So essentially the patient knows that they're having pain, but don't have the concern or anxiety that goes along with it. Let's go to our first question. So what are some of the assessment findings which we would see in a patient that has opioid abuse? This would be mild flu-like symptoms such as headache, vomiting, or diarrhea. May have an obsession about getting more of the drug. Psychomotor agitation. Sometimes we have patients that come in. We'll check their tattoos and stuff for needle marks, especially if the patient's unresponsive. Trying to see if we could possibly get a survey of what's going on with the patient. Sometimes the patient will have abscesses from IV use of opioids. The patient might also have seizures. There's a new drug that's out, Tana, not necessarily a new drug, but our younger generation of people have got a hold of this, and there's been several incidents where we have patients come in that family member found them down having in status, having seizures, and don't know why. And it's overdose of this drug. Depending on what type of state the patient's in, they might be in an intoxication state. That's meaning that they relapse and present with intoxication. Similar symptoms vary according to the level of intoxication. So they might be drowsy, have pupillary constrictions, and pupils might be really tiny. Slurred speech. Severe overdose, of course, we might see respiratory depression. We might have to intubate them based off how much they've taken. They might be stuporous, not responding to any kind of painful stimuli, maybe even a coma. And of course, if you've taken too much, it might be fatal. Withdrawal state, your patient might have an autonomic symptom such as diarrhea, rhinorrhea, runny nose, diaphoresis or diaphoretic, bicommentation, shivering, nausea, emesis, or pallor erection. Some central nervous system problems. Of course, this is where the opioid receptors are located. You may have sleepiness, restlessness, or tremors. Sometimes we get patients from the operating room that's received just too much of narcotics, and the first symptoms are when you see your patient, you know that they're drowsy, hard to wake up. Even if you sternal rub them, they can't hardly even move. That's a common sign and symptom. The patient might complain of having abdominal cramping, bone pains, or diffuse muscle aching. Might crave the medication. Might frequently ask for it. So what behaviors? The patient might have unreasonable demands. They might have had a prescription that was prescribed 2 days ago, and now they've somehow lost it, and they need more of the medication. That's a red flag. As some of the people in the hospital industry call frequent flyer, meaning they come into the ED, get pain medicine, and then leave. Or they sign themselves out of the hospital, it doesn't matter what they're getting treatment of, just to get the pain medicine, or even just to get IVs so they can give pain medicine to themselves. They also might steal medication. This has been a recurring issue lately. Family members actually, a patient seeking drugs, looking for drugs. We had to intubate a patient and had to lock all the drugs up while we were intubating the patient because the family members were searching for the drugs. According to the DSM-5, the patient may exhibit behaviors such as large amounts of opioids or taking opiates for a long period of time than that was indicated. A person might have went for minor surgery and now just they need pain medicine consistently. Spending a great deal of time in activities thinking of how they're going to attain it, how they're going to use it, and how they're going to recover from the effects. So anything expecting work, or we consider play, so social life, and anything that physically affecting them. They might have cravings, strong desire. They want to just use all the time. Might be unable to fulfill major role obligations at work, school, at home. May continue to use it even if it affects their social life or interpersonal problems. They continue to use even if they know it's physically hazardous. Continue to use opioids despite knowledge of having persistent, recurrent physical or psychological problems that are likely to have been caused, or even an exacerbation of taking too much of it. They might also have a tolerance. We all know that patient that comes in and we're trying to treat their pain because pain is what the patient says it is. So we don't want our patients to be in pain, but do you have that patient that has just a really high tolerance and it takes an extremely large dose to get the desired effect? Not only on nursing does that make you nervous, because as we talked about, it can cause respiratory issues, can even cause seizures. It's hard to treat these patients' pain. Withdrawal, as manifested by either characteristics or opioid withdrawal syndrome. These are all just kind of behaviors that you see a patient exhibit when they have opioid abuse. It's the best practice. A lot of our doctors prescribe only like a month, especially if it's a strong narcotic of some sort. They'll prescribe a certain amount of opioids. You might also have education for your patients on opioid substitution, maybe even a methadone tapering process, detox, finding appropriate ways to manage pain. Maybe sometimes people defer pain. Might be something mentally that's going on, so they might need counseling, or so there's ways that we can offer our assistance so that the abuse does not continue. In clinical practice, how do we address it? Make sure the patient's educated. Make sure they understand the drug therapy and side effects. We do a drug screen every time a patient comes in to see what they have in their system so we know what we're dealing with. So we educate, offer other ways to manage pain, comfort, repositioning, cold, heat, temperature control, sound control. All those things can offer a little bit of extra help when trying to deal with pain in a patient. I've enjoyed this discussion. Look forward to listening to everybody else's posts as well. This is a major problem in our society, opioid abuse, and as nursing we're told pain is what the patient says it is, and we're to try to treat that and relieve their pain. So I look forward to listening and watching the rest of the post. I will post my citation along with this discussion. Thank you.